Hi everyone, my name is Daniela Lisa Panesantón, and today I will talk about Belatacept and long-term outcomes in kidney transplantation. Content, definition, application in medicine, pros and cons, use in Ecuador, ENN approval, and conclusion. Definition: Belatacept is a fusion protein that blocks co-stimulation of lymphocytes by binding to CD80 and CD86 antigens. In clinical studies, especially BENEFIC and BENEFIC-X, belatacept has been shown to preserve the function and structure of the kidney graft and that its effects are remaining in the long term. Compared with calcineurin inhibitor, belatacept is associated with a lower incidence of chronic graft nephropathy and offers a more favorable cardiovascular and metabolic profile. Its efficacy and safety are mainly in donor kidney transplant with expanding criteria.
The use of immunosuppressive therapies in patients with kidney transplants has reduced the incidence of allograft rejection. The current standard of care immunosuppressive therapy includes calcineurin inhibitors, such as cyclosporin, plus anti-proliferative drugs, with or without maintenance glucocorticoids. However, calcineurin inhibitor-based regimens may not adequately preserve allograft function. In this 7-year extension of a previously published 3-year randomized trial, investigators compared the ability of belatacept and cyclosporin to preserve allograft survival and function. Belatacept is a fusion protein composed of the Fc fragment of human IgG1 linked to the extracellular domain of CTLA4. It blocks T-cell co-stimulation, thereby selectively inhibiting T-cell activation. 666 patients who had received a kidney transplant from a living or deceased donor were randomized to maintenance treatment including a cyclosporin-based regimen, a less intense belatacept-based regimen, or a more intense belatacept-based regimen as primary immunosuppression. All patients received basiliximab induction and mycophenolate mofetil and glucocorticoid adjunctive maintenance therapy. At the end of 7 years of follow-up, the belatacept regimens were more effective than the cyclosporin regimen. The estimated rates of death or allograft loss were about 22% in the cyclosporin group and about 13% in each of the belatacept groups. The estimated glomerular filtration rate was also higher with belatacept than with cyclosporin, suggesting that belatacept may be less nephrotoxic. The cumulative frequency of serious adverse events was similar across all 3 groups. Thus, treatment with belatacept as compared with cyclosporin reduced the risk of graft loss or death after kidney transplantation. Full study results are available at nejm.org.
Application in medicine. Belatacept preserves the function and structure of the kidney graft and is associated with a lower incidence of chronic kidney disease of the graft. In the long-term extension, renal function remains stable, with contrast with the annual decrease of 1 to 3 mm per minute per square meter that is usually observed with calcineurin inhibitor at a stable dose and is consistent with the result of the first year. The recommended dose in the initial phase is 10 mg per kilogram, and at the end of week 8 and 12 after transplantation. In the maintenance phase, the recommended dose is 5 mg per kilogram every 4 weeks, starting at the end of week 16 after transplantation.
Fundamentally, the drugs that we use today are very similar to the drugs that we've used since the 1980s. 1983 was the drug that revolutionized transplantation. Cyclosporin was introduced. Since then, that class of drugs, another drug very similar to it, have been the cornerstone, the foundation of immunosuppression. So it's been since 1983 since we've had a new drug that has formed the foundation of transplant, preventing transplant rejection. rejection is caused by an immune response, an immune reaction against the transplant. And when we reject an organ, we have to recognize it as foreign, and then we get these other signals, co-stimulatory signals that turn on the immune system. What Belatacept does is block those co-stimulatory or second signals, and therefore it aborts the rejection response.
Pros and cons. There is good adherence to treatment, a stable kidney function, good safety, and predictable pharmacokinetics with Belatacept during a 5-year follow-up. Regarding cardiovascular risk factor, there was a slight increase in systolic and diastolic blood pressure between 24 and 60 months with cyclosporine, with final values of 138 more or less 18.9 millimeters of mercury and 83 more or less 8.9 millimeters of mercury respectively, versus 125 more or less 13.9 millimeters of mercury and 17.6 more or less 10.1 millimeters of mercury respectively.
Welcome back to the Transplant Medications video. Belatacept is used to prevent rejection of your transplant. Belatacept is the generic name for Nulogix. You will be receiving it IV, which means it will be infused into your vein. Belatacept IV infusions will be given more frequently early after transplant and will eventually become a once-monthly infusion that you will receive lifelong. You will be given a schedule of your infusion appointments. It is important that you don't miss any scheduled appointments or move your infusion appointment to a different day. If you are having trouble getting to your infusion appointments, tell your transplant team immediately. Most people don't have side effects from this medication, but just like all of the anti-rejection medications, it can increase your chance of infection and cancer. This concludes the Belatacept video.
Is applied in Ecuador. According to Index, 44 hospitals are accredited to perform transplants nationwide. The annual donor rate in the country has increased in recent years. It currently reaches 7.76, that is an additional 2.71 compared to 2017. Likewise, in the last 12 years, a total of 5,454 transplants have been performed, of which only in 2018 there were 714. EMA approval. In June 2011, the European Medicines Agency approved Belatacept for its combined with corticosteroid and mycophenolic acid in the prophylaxis of graft rejection in adult patients who have received a kidney transplant. It is the first biological agent to be approved for this indication, and for a decade, the first immunosuppressant with a new mechanism of action.
When I found out I needed a transplant, I was fairly worried and a little bit scared, to be honest. The likelihood of finding a match soon are fairly slim. Not many people in our community do donate. I've been given an approximate time of a 10-year wait. That was kind of disheartening, to be fair. I think now, as more generations are born here and grow up here and learn about things, they understand why it's important and how it can help and save people's lives and improve their lives.
Conclusion: the use of Belatacept has background therapies in kidney transplantation preserve kidney function and is associated with a lower incidence of cardiovascular risk factor, and noted the inclusion of Belatacept in immunosuppression protocols in kidney transplantation can lead to a significant improvement in patient graft survival.
When my doctor in the community first said to me, you're going to need a liver transplant, I thought, what are you talking about? You're not talking to me.
I'm James Spivey, and I'm the medical director of the liver transplant program at the Emory Transplant Center. We have this wonderful multidisciplinary collaboration between a number of physicians from different departments, including our radiology group, our laboratory group, the pathologist, all of these services essentially under one roof.
I felt like I was in good hands, that I had walked into a place that understood what I was facing and that they were going to take care of me.
There are a number of exciting developments in liver transplantation, not the least of which is development of new immunosuppressing agents.
Transplantation today depends upon drugs that suppress the immune system and prevent rejection. The problem with the drugs that we commonly use today is that not only do they suppress the immune system, the desired effect, but they also have side effects. They can cause high blood pressure, high cholesterol, kidney toxicity, and diabetes. So for the past 15 years, our group has worked on developing new drugs that would have those desirable effects, preventing rejection, but would avoid those toxicities and side effects. The burden on the patient is just potentially greatly reduced.
My surgeon told me that the new liver started producing bile before he was finished sewing it in. The aching and the itching and all of that, it was gone immediately. I woke up from surgery feeling better than I could remember feeling in a long time.
Emory is a leader in basic research in transplantation. Efficient, thorough, compassionate care is what we're trying to deliver.